It's my privilege to introduce us to Dr. Ngozi Ezike. Dr. Ezike is a board-certified medicine pediatric physician and became president and CEO of Sinai in Chicago, which is the state's largest private safety net hospital system, in June of 2022. Prior to this, she was the director of the Illinois Department of Public Health, where she valiantly navigated the state through the most difficult waves of the COVID-19 pandemic. At Sinai, Dr. Ezike has focused on advancing health equity through innovation and creative collaboration. Sinai Chicago is a really unique organization as a combination of Jewish and Catholic healthcare institutions focused on carrying out faith-based commitments grounded into shared value of caring for those in the highest need. Under Dr. Ezike's leadership, Sinai Chicago has expanded community health worker programs and invested in state-of-the-art technology. This has allowed Sinai caregivers to work better and faster to provide care for the patients who need it. Also under her leadership, Sinai Chicago's commitment to the uncompensated charity care program has been recognized in the top 10% nationwide of safety net providers. Dr. Ezike is a nationally recognized public health leader. She holds degrees from Harvard University and University of California, San Diego, and a business management certificate from the Harvard Business School. She's a recipient of dozens of awards, including Crain's Chicago Business Woman of Note, Crain's Notable Leaders in Healthcare, and the Jane Addams Medal of Freedom. She has also received USA Today's inaugural Women of the Year Award for the state of Illinois. We are thrilled that she is here with us today, and Dr. Ezike will speak on the topic of faith-based safety net care and advancing health equity. I invite you to go ahead and share, Dr. Ezike, and we will have time at the end for questions and answers. Thank you very much.
Thanks so much, Dan. Good afternoon, actually. Good afternoon. As introduced, my name is Ngozi Ezike, and I see that on the introduction slide, I'm wearing the exact same outfit, but I do have other clothes. But I'm so proud to serve as the president and CEO of Sinai Chicago. I am humbled and honored to be with you this afternoon, and I'd like to thank all of those who are involved with inviting me here to participate in this theology, medicine, and culture program. It's really an honor to join you and discuss a mission that is both a calling and a responsibility. You know, faith-based safety net care and its essential role in advancing health equity, which it does every day. You know, as people of faith and as healthcare providers, we are called to serve. We are called to heal. We are called to uplift the most vulnerable among us. Like, this is what our faith tells us to do. This is it's more than just a moral obligation. Like, this is our faith tradition, and it's rooted in love, and it's rooted in justice and the sacred dignity that every life requires. So for me personally, you know, I like to say that I wear many hats. You know, I'm a Christian woman and leader, and so my faith is very vital. It's the anchor upon which I do what I do, and so this relationship with God is really who I am and how I approach my life, how I approach my work, and it's helped me learn the importance of showing humanity and compassion as a leader. And that's who I am. I try to bring my, true self to the role. I don't feel like we can really partition ourselves off into parts and, be a Christian at home and, be a doctor here. Like, all of it is what forms the whole and who I was knitted to be. So as a physician, of course, we take the oath to do no harm, but as a woman of faith, we're also called to love everyone, and we are called to serve. And And then as a mother, I have those instincts of also trying to be caring and nurturing. Um, I grew up, I was a child of immigrants. I didn't grow up in Chicago, although all of my professional life has been in Chicago. I grew up in Los Angeles. Um, Humble beginnings, but completely excited and proud of about how, but we didn't have a lot of resources initially. I do remember, you know, only being able to get dental exams when there was like a health fair that was happening at the in the local park where there would be some kind of health fair, and we try to get up really early and get in line so that we could get, a dental exam. And so I think some of that probably shapes me. I think we're a sum of all of these experiences. Um, but I knew early on, I'd like to say I knew early on I wanted to be a doctor, but that's because my dad decided he wanted me to be a doctor, and I was complicit in that. But he wanted his firstborn to be the first doctor that there ever was on any side of the family. And he thought that that would be a way that maybe I wouldn't struggle financially. But, it became more than just a way to pay the bills. I know my dad decided I was going to be a doctor, but I found my calling in residency to actually serve the most vulnerable and underserved communities. And so that's how I ended up in Chicago and stayed in Chicago because I was so excited to work at Cook County Hospital, which is the big public, kind of world renowned public hospital that takes care of everyone without regard for their ability to pay. And as a internist and a pediatrician working in that hospital, you know on call, you would be called to the ER for patients who literally got off the plane from some faraway land and took a cab to Cook County because they were looking for a place to get care. And so it was a very special place where it, there was no wallet biopsy. You just take care of everyone that comes through the doors and give them everything that you have to offer. And as you take care of all of these people, you get to see like all the other parts that play into health, besides just genetics, besides just your ability to access care. And I saw that even more as I delivered healthcare in jails and detention centers, which were operated by the Cook County, the government system, and really understanding how people end up in the predicaments they're in and how those predicaments impact health. It was, even though, continues and continues, if your eyes of others and you're curious and want to understand, how you can be a part of the solution and, exactly, what those factors are. I got that unique opportunity in 2019 to leave the county system and serve with the governor of Illinois, still the governor, Governor J.B. Pritzker, to serve as the department's of public health director. And, IDPH, the Illinois Department of Public Health, is responsible for hundreds of public health programs and initiatives, all across the giant state of Illinois, of which, Chicago is the most populous city, but, in Cook County, but there are, 101 other counties. So I took the position at IDPH thinking, oh gosh, what a great idea and what a great opportunity to serve on a bigger scale and really take some of the things that I learned working with some of the most vulnerable people in our state and making sure that our programs and initiatives incorporated those special needs to promote, health equity and try to narrow these disparities. So was excited to take that on. I didn't, know that part of that tenure would include, a global pandemic. And truthfully, I don't know if I would have taken it in the middle of the pandemic, but God knows best. I'm glad I didn't know, because, you know, I clearly had a role to play. A lot of my, my circle and my, sisters in Christ were like, this is like Esther for, for such a time as this, that is what you're called. And so being able to be obedient to that call, it is an honor in itself. I was, I think, only the second woman to ever lead the organization, the second woman, the first Black woman to lead the organization. It's almost 150-year history, and so many. I mean, obviously, COVID was something beyond words, and my team and I spent long days, long nights, trying to learn all that we could, trying to be able to get as much information on this rapidly evolving situation so that we could shape a response for the state of Illinois, so that we could educate people, so that we could ultimately prevent the spread. And then, at the appropriate time, once the vaccine was available, explain to people why they should get vaccinated and how to get vaccinated, and all of that. Unfortunately, as you probably recall, it was an atmosphere that was very charged with political overtones, and there was the misinformation, the disinformation, and there was fighting amongst the people when our enemy was the virus. So that was a little overwhelming, and it it's something that actually made me have to lean into my faith even more to get through these, very difficult days, including, personal and very significant threats. But, uh, across the state, we were trying to keep as many people alive as possible. But it led us into this crazy new existence of, working from home and remote schooling and more video conferencing and, also isolation. And it was, as we delivered press conferences every day to the people of Illinois, we were hoping to give them information, but also provide hope and assurance that if we could do some of these mitigation factors, that we could get to a better state. So that was just an incredible part of my life's journey. And after I finished that and was able to think about what's next, we all know that the COVID pandemic really laid bare something that people who work with less resourced communities already know, but I think it was laid bare for everyone about how any kind of adversity or pandemic or disaster emergency will disproportionately affect those who are already struggling. And so when you're thinking about ways to uh, help those that need the most, um, that's an intentional mindset that has to be employed. And I when I got an offer to work for Sinai Chicago, this is, a 3 hospital system whose hospitals are in the, by all measures, the economic indices, the rates of um, educational indices, the rates of high school graduation, college graduation, household income, also the health indices, highest rates of chronic disease, lowest life expectancy, all of that. Being able to serve in that setting seemed like an incredible extension of the work done at the state, taking it to a much more local and focal area to see how we could turn the tide on some of these kind of gloomy statistics that are the norm. So I joined Sinai Chicago, seeing that the community, again, had been more devastated by COVID-19 than communities that were just a few miles away, but had, were more resourced. And it was another opportunity it has been an opportunity to just kind of roll up my sleeves and all of our team to see how we can make this lift these communities up, through the services, both clinical services and social services that we're able to provide. We have a service area that includes about 1.5 million people. We employ almost 3,500 caregivers. We have 2 acute care hospitals and a rehabilitation hospital. And then there's a network of outpatient clinics. We serve over 150,000 patients a year with 76,000 emergency department visits. And we're a major, major training ground. People say that if you trained at Sinai or you worked at Sinai, you can work anywhere because we are, a level 1 trauma center. And unfortunately, we're also in the midst of communities where violence, interpersonal violence is a significant factor. So we train the next generation of clinicians, if you will, because over 1,500, 2,000 medical students, physician assistant students, pharmacy, nursing, like all, fellows, everybody is training in there at the same time. So we are, we're not an academic institution, but we're an incredible training ground for the next gen of clinicians. And so we've been around for over 100 years and have always served these underserved communities in Chicago on the west side and the south side. And so our caregivers are dealing with the gun violence. They're dealing with patients who are on the receiving side of racism and higher rates of chronic disease and economic inequity. The community that the flagship hospital is in is called North Lawndale. There's not a single grocery store in the neighborhood. So imagine, trying to encourage people like we've got to, prevent diabetes, or we've got to control your diabetes. So we need to think about what we're eating. And when you think about not having a grocery store and the obstacle that is to even get fresh fruit or produce, then you see the complexity and the difficulties associated with actually turning some of these unfortunate metrics around. And so that's why our system is called, to partner with community to try to address these things. And so we don't just heal the wounds, but we partner in community. We're actively trying to bring a grocery store to the neighborhood. We have social services programs that go into the house because we have to follow up after you leave the hospital to make sure we can maintain health and not just Band-Aid you and have you, come back soon after. So I just want to make sure I fully define this term of safety net. Simply put, a safety net hospital is a medical facility that provides care to people regardless of their ability to pay. So that's what I was drawn to when I moved to Cook County Hospital, and Sinai was the same thing. Unfortunately, not doing it from the government side, but doing it privately, which is a very tricky task. And I would say I think in the last 10 years, maybe over 1,000 hospitals have shuttered. And you can imagine that many of them would be safety nets that are trying to do essentially what I call God's work, but not having the resources to fill the gaps that happen when you take care of the uninsured or underinsured like we do. So we have this mission to serve the sickest patients and the most vulnerable communities and ensure access for our largely Medicaid population. And it's almost a catch-22 because, you know, when you're taking care of people who are sicker, um, you actually need more resources, not less resources, but the reimbursement that you get from Medicaid is less than what someone who is commercially insured would get. And so the safety nets have this, you know, eternal struggle of having slim to negative margins, while still bearing all the high costs that any healthcare system. And oh, you know, past the pandemic, we have labor shortages, which means you're competing for what we, you know, our staff or caregivers. And then where does that leave money to do the infrastructure upgrade so that we can have the shiny new building, so that our patients can have a beautiful edifice in which to get their care? That becomes super challenging, and those new buildings don't get put up, and the generous perks to these caregivers, these staff members that have chosen to serve the underserved. We're unable to give them these, you know, great perks and bonuses that they deserve. Instead, we will get awards. You know, like we did $50 million of charity care last year. And so we'll, you know, get awards and designations that, oh, you know, this is one of the top hospitals in the country that does the most amount of community investment, that does more than their fair share in giving back. But at the end of the day, it doesn't cover the gap in terms of the dollars necessary to cover people who not even are just Medicaid insured. That leaves a gap because the cost of the Medicaid reimbursement doesn't cover the cost of care, but the people who are completely uninsured and you know, are self-pay and that we won't collect anything on. You know, we're dependent on philanthropists and grants, and you know, try to get other sources to continue this incredible mission, but this costly mission as well. So in essence, our economic realities um, fly in the face of the mission that we're trying to uphold. But you know, I have a bunch of teenagers at home, and you know, one of the phrases they say, you know, the math ain't mathin'. That's definitely the case in safety net, in private safety net healthcare. You know, it's a flawed model, and we hope that we will, as a nation, be able to come up with a system that allows everyone to get the care that they need, and allows hospitals that provide care in these traditionally, historically under-resourced, underserved communities, that allows them to um, have the resources necessary to step up what they're able to do for people who absolutely need it the most. So a little bit about this, you know, mix, because we are a 3 hospital system, and it was started, um, I mean, it was grounded in Judeo-Christian traditions. Um, it's an amazing story, actually. There's a Jewish phrase, tikkun olam, and that means heal the world. And it's been a guiding principle of Sinai since it was founded by Morris Kurtzon in 1919. And it's amazing that, you know, this uh, founded the hospital because, you know, uh, he was Jewish, and because of, you know, discrimination and racism, um, one, you know, nursing student, Jewish people who wanted to be nurses, Jewish people who were doctors, like they were not allowed to practice at all hospitals. And so he wanted to create a hospital where they could train, where they could work, and where they could give that culturally competent care to people of that same background. And so it started like that, and you know, serving a largely Jewish community that didn't have other options for where to go. But then when the communities started changing, the leader at the time said, invoked this tikkun alam principle to say, yes, the community has changed. Americans that had moved up as part of the Great Migration from the South. They said, but these people need this care. So we're not going to move this hospital away. We're going to stay in place and serve this new community that has formed. And then we had this, talk about, diversity. We joined forces with Holy Cross, which was a Catholic hospital. Sorry, a Catholic hospital that was started by the Sisters of Kazimir. These were Lithuanian nuns. And so through this combination, we have had this, eclectic Judeo-Christian valued system that believes in taking care of all. So this, ecumenical array of shared religious narratives, it frames the dedicated altruistic faith witness, which we hope touches everyone who comes through our doors. We are, living out our faith through healing and serving, and really, lifting out our witness through service. So there's this respectful collaboration of the Catholic and the Jewish tradition. The Catholic hospital maintains its Catholic identity and follows the United States Conference of Catholic Bishops' ethical and religious directives for Catholic healthcare. And so the integration of these two hospitals has created a sustainable network that has expanded access to people, both inpatient and outpatient. There's community health education, there are wellness programs, always in transition, but faith-based hospitals have always played a vital role in public health. And so providing these essential services, especially to communities who need it the most, has become even more critical. And as we look at these inequities that even further expand the gaps, if you go from some of our communities to just go 5 miles, you'll see like a 20-year difference in life expectancy. And people will say, oh, it's all due to gun violence. No, the major contributor is chronic disease. And so being able to create not just the healthcare, but the other things that are needed to help decrease those chronic disease rates and help people control it, that's an important thing that all of us need to be working towards. So that's our great challenge, addressing the severe inequities. And these inequities limit opportunity. You can't be a productive student if you're not healthy. You can't be a productive member of the workforce if you're not healthy. So the safety nets, obviously we know that the cycle of poverty has been, especially for our communities, is tied into many things, including, all levels of racism that has created some of these impoverished communities. And so, a lot of work by a lot of people in and outside of healthcare is actually necessary to impact and affect the better results that we all hope for. I think I want to move to, so there's a lack of economic opportunities, there's a lack of educational opportunities. We talked about the food deserts. There are, the communities that we live, even the air is more polluted, so more hazardous living conditions, which is the reason that you see those disparate rates of asthma in people who are from inner cities. So all of these things tie in together, and that's why the call for advancing health equity is so strong. We have to assert that healthcare is a basic right and not a privilege, and that's at the center of our faith-based mission, and why we're so proud to take care of everyone. We do take our responsibility to be healers very, very seriously. It's never been easy work. When I try to round in the different hospitals frequently, part of it is just to say thank you, caregivers. Thank you for um, for choosing to share your gift and talents here, because everyone knows that it is so much easier to work in a well-resourced hospital, and you'll still be caring for people, because we don't have all the bells and whistles that make the work easier. But these individuals have chosen intentionally that they want to serve this community. And even in just my 3 years, we have gone through all these constant financial challenges. you know at a point, we weren't, not even that we weren't able to give people like COLA, like cost of living increase, but we actually had to give salary cuts to our leaders. And can I just extol and lift up the fact that even having to do the unthinkable, and rewarding people for their incredible service with giving pay cuts, because we just were trying to close some of these budget shortfalls, not a single manager or director or leader left despite that. And so just speaks to what's people's service, what it's anchored in, and what's driving people. And that's not the goal to be cutting people's salaries. We really want to have a system that allows us to respect the people who've chosen to honor this calling. And so we hope for good decisions by our government leaders to solve this problem of how we can take care of all people. I there's this, it's not, there's not, people try to say science and faith, that they're at odds with each other. I don't think so. I remember somebody asking me in the pandemic, like, oh, you consider yourself a woman of faith, but you believe in science. I was like so baffled. I'm like, they are not at odds with each other. um, I, I think it's very important that we respect cultural religious beliefs, and I think they have an incredible role in providing um, patient care. And um, religious beliefs can influence medical decisions. Um, I know that in some religions it may affect, you know, refusal of certain treatments, but I think the part that's important is not really religion, but the compassion, the relationship with God, that says that all of these people matter and all of their lives matter, and that we are supposed to be compassionate and go out of our way to help those who are less fortunate. And so it's an honor to be able to train staff to practice cultural humility. We have a lot of doctors that don't come from the backgrounds that our community is. Our community is 90% Black and Latino. And so being able to train staff to practice cultural humility is something that these medical professionals will take with them wherever, wherever they go, or even, hopefully they're staying with us. So I want to, another challenge that we try to strike is the delicate balance between clinical efficiency and personal engagement with our patients. We want to provide the highest quality of care. We want to provide compassionate care, and we don't want to compromise operational sustainability. So there's constant pressure for more efficient, more efficient. Um, but as I said, we're working with the lowest amount of resources. And so our doctors and nurses, they have to make rapid decisions while managing like the sickest people in the city of Chicago. And not just their situation clinically, but their social condition, which plays into, you know, in this world of managed care, and the insurance companies will say, oh, for this condition you should only be in the hospital for 3 days, and so you're dealing with a patient that might be a little more complicated clinically, but then the additional challenge is that you might find out now that they don't have a place to go home to, and you're not discharging to the street. You don't no DC, DC home, not DC to the street. And so then you're spending time trying to find a place that can house this person, or is there a place that can provide maybe the limited amount of medical care that might be needed while this person is convalescing. And we know how hard that is when people don't have resources, how few the options, how limited the options are. And so you're keeping the person in the hospital because you have nowhere to put them. And so that means they stayed 5 days while you were looking for somewhere to go, but you're only getting reimbursed for 3. That is like the kind of everyday struggle that is experienced, in our safety net hospitals. So we build strong patient-provider relationships, and that helps to improve health outcomes, because if someone doesn't trust you, they're not going to follow your advice. They're going to be thinking twice about the regimens, or maybe they'll think, I don't know if that medicine will help me because I don't know if I trust you. So that is super important. And we also have to bring to the table trauma-informed care. We have to be cognizant of the fact that a lot of individuals in our community have been directly touched with violence. And so having that lens is very important in taking care of our patients. And we have to know that, our as Black and Latino people, the amount of discrimination that they face on a regular basis, we have to go out of our way to not look like that in our interactions, and even things that might be innocent, that someone who has been on the receiving side of so much discrimination, if we're not more intentional about how things might look from the other side, we could inadvertently chip away at the trust that we are trying to build. So we balance our clinical efficiency with the personal engagement. We navigate these resource constraints. We're trying to build trust. We're maintaining connection. We're leveraging, team-based care. We're working with community health workers. Community health workers are really, you know, a piece of the healthcare ecosystem that is also an economic support to the community health workers. And it's something that we almost created at Sinai starting like 25 years ago, was an opportunity to have people in the community who understand the community, that speak the language of the community, understand what the community is going through, that they are able to be trained to screen for some of these social determinants that might be impacting health outcomes. And so whether they are helping connect, interviewing patients and helping connect people to resources that might be available to help their situation that maybe before were unknown. Sometimes it's specific training in a specific disease entity, say maybe asthma, and following up in the home with patients that have been discharged to make sure that, a couple of days later, that the patient is doing well at home, that they have the inhalers that they were sent home with, that they're making sure that the different types of inhalers, like the rescue inhaler versus the steroid inhaler, that people understand the difference and aren't reaching for the wrong inhaler if they're having an asthma attack, and that they have a follow-up appointment. Like those little follow-ups by someone from the community coming to the home and making sure that all these things are in place, we have shown that that has decreased the at readmission rates for asthma patients by 40%. And now these community health workers are gainfully employed by the health system, which means that they are earning a livable wage. They are now properly insured and can take care of the healthcare needs of themselves and their family with their livable wage. So we're excited for the great economic impact that we can have by hiring community health workers, by training them and helping them to be an extension of the healthcare team as part of this comprehensive approach to care. And we have lots of other social services, as well. Um, I'm just looking at the time here, you know, let me see. Mm, I'll give this example. We had a baby girl who was born at Mount Sinai at just 26 weeks. Normal gestational period is 40 weeks. So born like 3 months early and weighed less than a pound, right? Average birth weight is like 7 pounds. Um, the team detected a blood clot in the baby that was causing her to lose most of her blood volume during the delivery. But we have the highest level NICU, and our outstanding neonatal intensive care unit was able to save this baby's life with multiple blood transfusions. And so that's just the initial. And then, now you're dealing with a baby that's not even a pound and trying to, underdeveloped lungs, and that baby was in the hospital for months getting that personalized care, and the baby and her very grateful parents were able to get her home. She was able to be able to get to transition to home, and do very well without even needing any home health needs. I mean, it took many months, but that's the very critical work that happens in the hospital and then would be followed up with community health workers to ensure that other needs are being met. We provide every baby that's born at Sinai with 6 months, 6 months of diapers. So you just keep coming back to the hospital to pick up diapers. As the baby gets bigger, you're getting the bigger sizes. But we know that diapers are expensive. And even when I was in the outpatient world, I remember vividly having babies come in for their checkup with these raging, diaper rashes in the perineum, in the buccal area. And it's not, if you ask the right questions and you build the trust, people are saying, I can't change a diaper every time the kid pees. Like diapers are so expensive. I can't go through 10 diapers a day. And so being able to address that and take that barrier away is something, that is necessary for the communities that we serve and has significant impact, because some of those diaper rashes that I've seen in the past have spread, like these severe penetrating, widespread rashes have spread and sometimes even become systemic. So we are constantly looking at the ways that we can support our community. Again, doing this with the shoestring of budgets. But if you actually want to make a difference, these are the things that matter. And so sometimes we get philanthropic dollars to support this work and to help us fill in those gaps. Another major thing happened, just 2 years ago. We successfully transitioned to the EPIC it's the state of the art medical record system. Many people, maybe many of you might have my chart actually on your phones, but it's the biggest technological investment that has been made in the hospital's history. But bringing that state of the art electronic medical health record allows us to improve the quality, allows us to increase patient experience, allows us to see that you were at, this other hospital 2 months ago and you had the same complaint and you had these tests done, so we can avoid starting all over and doing those same tests. It helps us when someone comes in and says, wait, when we ask what medicines are you taking, and people are describing their medicines, oh, a little purple one and a triangle one, but I can look in our system and see you were last at this hospital across the street or in another town, and these are the medicines you were taking. You can confirm that these are the same medicine. These are the kinds of no-brainer things that are necessary to give our patients the best care, but have been elusive because of the costs and because of the system we have where we have less resources. But we are continuing to try to overcome these challenges and continuing to innovate, and the proverbial do more with less. And we will continue to do that because we know that this work matters and we have families that are counting on us. Of course, we can't do it alone. We work in partnership with other hospitals. We work in partnership with the federally qualified health centers. Lawndale Christian Health Center is one of our close neighbors. They're serving the same community, and so they are some of our strongest allies, and they're our major referral source. And we also partner with the Chicago Department of Public Health and the Illinois Department of Public Health and community organizations in all of our surrounding times. We have many impactful community partnerships that help us. There's a African proverb: if you want to go fast, just go alone. But if you want to go far, go with others. And so partnering with the community to help leverage all the resources that are there, you get this, synergistic effect. And so we know that that is a very important way to move forward. We also have to engage very closely with the philanthropic community. There are people that believe that healthcare is a right for all, and that we should be able to give all these supports that are necessary to communities that have been traditionally marginalized or disinvested in. And so spend a lot of time with we call it the advancement team, the development team, the fundraising team, whatever word that is used, to engage and just lift up the great work we do, and find those people who say, I'm all about that. Like, how can I want to sow a seed for that work? And so there are individuals, there are foundations, local in the city, but also like nationally. And we're always welcoming the support and generosity of people to help us with this work. Every single contribution is important. I started, you know, give a
So I'm
lot of,
listening to a live thing. What?
I give a lot of talks, and I now,
Thank
people say,
you.
oh my gosh, this is really great what you do. Like, how can I be a part of this? And so now my business card, I got new business cards that have QR codes, and I'll say, scan the QR card, scan the QR code for a chance to donate directly to Sinai and tell us where you want your money to go. So I don't leave home without those cards. But as we wrap up, there's a lot of work to be done. There are a lot of people that have been left behind, and it's our role to go find them, to go serve them, and we need to end these disparities. For all of us that have been working in the space of public health and have always worked with communities in need, we know that these problems exist, and so we want others to join. We want others to join our work. for those who are already on the front lines of care. Like we keep at it, but we definitely need more support. We need to be thinking about our safety nets and figuring out how are they making it. How are you mostly Medicaid and making it? And so we need other health systems that are more well resourced. The Dukes and the Northwesterns and the Cleveland clinics. They need to be looking out for the safety nets and looking for ways to partner and looking for ways to support those systems that are taking care of the least of us, because there are real obstacles and we can't do it alone, and we need to go together to go further. We can't continue to look at these higher levels of chronic illness and increased mortality and cancers that are readily treatable that people are still dying from. We need to step up. If COVID taught us anything, it taught us that there are no walls between our communities. We're only as healthy as our sickest neighbor. And so this sense of rugged individualism and just thinking about me, myself, and I, that's not consistent with our faith tradition, even if it's ingrained into our maybe national culture. We definitely saw in the pandemic that concept of rugged individualism does not work. You have to be thinking about what you can do to help others. And so that is more the model that we're looking for. What
Thank you, Dr. Ziki.
things
Um, that was a really inspirational and far-reaching presentation. We have a few minutes left for question and answer. So I'm wondering if we could take the slides down, and you can either present your question and answer in the chat or raise your hand. And we would love to have those who are attending hear from you personally on some things. There's one question that's there immediately, and I can think of a few others, but feel free to raise your hand. One question comes out about what programs in terms of spiritual formation or social formation have you used with your caregivers? And I would add to that, like, have you found to be effective? You're doing really hard work, often for less pay. And sometimes it's hard to keep people motivated and involved. What are you doing at a practical level that you really think this works? This is something that should be replicated.
Yeah, I will be very transparent that I think there's something in the people that choose us that, they're already bought in. So it's not like we're trying to
Mhm.
convince or, encourage them. I mean, we have uh, interreligion faith hour where we have prayer that happens across whatever your faith is. So Jewish, this Catholic, Muslim, we come together. We have our religious leaders, the Catholic priests, all the different faith leaders come together and lead that, quarterly. Um, we have a vice president of mission, and so that person's job is to keep up with the spiritual formation, specifically at the
Mm,
Cross campus. So that's a very important role. There are masses that are held. There's a church within the Catholic hospital where mass is held, and that chapel that is there is a place where um, you know corporate prayer can occur whenever people want. So I don't think there's as much, we celebrate, many of the different rites and traditions, but it's really based on the people who have chosen to come and stay. Like it's internal, and then I think it's fueled because others
mhm,
are feeling it too.
mhm. Thank you for that. Would we be able to replicate that in many places? Um, we probably have a time for one or two other questions if anyone wants to raise their hand or come off mute. Um, I'm just wondering, at the beginning of your presentation, when you did your introduction, you mentioned when wearing many hats, and I can see and relate to many of those. I wonder how there were particular pinch points of those hats, either ethically or in your personal life in the middle of the hardest moments of COVID? Where are those places where your hats, where it wasn't actually possible and you might have had to make a really hard decision professionally or for your own self and your faith life?
That's a great question. Politics is it's a tough game, and so when for the most part, I don't think I compromised too much. I know there was one issue where, when we were coming up with the order in terms of who should, what's the order of who should get vaccinated first, and largely
Mm-hmm.
to follow the CDC recommendations, but I made some changes based on the fact that, the first after the healthcare workers and the nursing home residents, the next group was like the 75 and above. And I was like, it cannot be 75 and above because our Latino and Black populations, many of them don't
Mm-hmm.
age.
Mm-hmm.
So you're going to
Mm-hmm.
vaccinate, like not vaccinating, entire communities because they don't get to that age. And so um, I had to, present the data, show it, and say, on an equity stance, like if we're being inclusive. So actually that came up, but I was able to make the argument and be convinced. There was another one where they were like, there was a group that had no business being elevated, but it was, a political, maybe some other thing going on. And so, I'm saying there's no reason, like they're not at higher risk. They shouldn't move up to the line. But, some of those,
Mm-hmm.
are more politically savvy. We're like, Ngazi, pick your battles. Like,
Yeah.
go.
Yeah. Yeah, thank you for that. Okay, I think we need to close as it's 2 o'clock. Thank you again, Dr. Ziki. I wish I could sort of suggest that you show your QR code to us, but I'm sure that many of us can go online and learn more about Sinai Chicago and this unique place of meeting of faith and healthcare. We really appreciate your time and your work. As was mentioned at the beginning of the presentation, Dr. Alexander Martin will be our final TMC seminar for the spring on April 4th from 12 to 1 Eastern Standard Time, and we hope you'll be able to join us then. Thank you again for your time and preparation and for the remarkable work that you're doing.